Here, I want you to think of the mentalis as being a broccoli. It has its origin under the labiomental crease. Sebastian will show us that in a bit. And as it comes up to the surface, it's actually angled slightly downwards, okay? And as it comes up to the surface, it sort of spreads out like a broccoli and has all these fascicles of muscle that are inserting into the skin. Stick out your lower lip again. See what happens? It pulls out the lower lip and it pulls the chin up like that. Right. Anytime I do a chin enhancement with filler, I automatically treat the mentalis. You want to take away the shear effect of what you do when you're trying to do an enhancement or an augmentation. I do the same thing with the dorsum of the nose. If I'm treating the dorsum of the nose to elevate it, I also treat with toxin for the nasalis. Okay? So what are we going to do? Are we going to inject superficial or deep? Here's the way I think about it. Remember, the things that I tell you are not cast in stone. This isn't the Bible. Just because Swift says it doesn't mean that's the way it has to be done. What I'm trying to do is to get you to think of what you do before you do it. That's all. I'm trying to think of why I would treat the chin differently. Normally, what I do is a 3-point injection technique using probably a total of about 10 units of Botox or Zeo, 25 units of Dysport. And I'll inject, can you stick out your lip again? As you can see where she's corrugating, I would inject here, I would inject here, and I would inject here. Okay? All those injections are below the level of the labiomental crease. Am I injecting superficial or deep? And the answer to me is to inject superficial because this muscle has come right up to the skin and it's inserting into the skin, so it's a similar injection to what we do over here for the tail of the corrugator. Except, if I have a patient with a deep labiomental crease, this injection over here is going down deep to the origin of the muscle, because the mentalis contributes to that labiomental crease. Some people have it very deep, some people don't. So that's the way that I alter it. Can I have my toxin, please? In her case, she has a reasonable labiomental crease, not that deep. I can go either way. Yep. We're going to clean it up a little bit over here. You're good? Mm-hmm. And I'm going to show you, keeping my hands out of the way, a little pinch. There we go, very superficial, a couple of units. This is Zeo that we're using, and we're done. Okay? That's treatment of the mentalis. Why do I not go deep on these different lower injections? Because you have another muscle that's deeper underneath there, which is responsible for pulling down the lip, called the DLI, depressor labii inferioris. And if I catch that one, smile, what's going to happen is the one that I don't catch is still going to pull her lip down, and it's the one that the lip stays up on that has the problem. Okay? So we're going to have to treat the opposite side if we catch that. So that's mentalis. It's pretty straightforward. It's a great little thing to treat. You know, if you don't look for things, you'll never find them. It's the old story. Things are hiding in plain sight. I can't tell you how many patients I had come into my practice that had huge masseters, but because I thought I had nothing to treat them with, I never bothered looking at them. The second that I started realizing that we can use toxin to trim down masseters, all of a sudden everybody had big masseters in my practice. So it's the old story, you know. That's not because it's because you're aware of things that you can treat, then it opens up your eyes to it. We're going to look at the DAO, which is another muscle that I like to treat. And the DAO is responsible for pulling down the corner of the mouth. So in patients, what happens is as we mature, it's a couple of things. Gravity has more of an effect. We lose volume and we lose structure underneath as the bones are shifting and the volume decreases. And that is the situation with the lower face. So that as you get a volume loss in this area, which we call the marionette zone, the lip corner will drop down into it. So we like to go ahead and to put structure back in there, but you also have this muscle called the DAO, which is pulling down on it. DAO, as Sebastian's going to show us, is a superficial muscle. And it can be quite expansive. People used to think that it was a continuation of the platysma, but it isn't. It's a separate muscle, embryologically, as we were talking about this morning. And it actually, what it does is it can spread. It's shaped like a triangle, and it can actually be quite wide in its base. Now, unlike other muscles of mastication, I think I got this right, unlike other muscles of mastication, or not mastication, of expression, mimetic muscles that can insert into the modiolus, which is this little fibrous thing about a centimeter and a half lateral to the oral commissure, the DAO actually inserts into the lip, correct? Not into the modiolus.
The DAO?
Yeah.
Well, it does both, actually.
Does it do both?
It has some small fibers, and I can show you these ones. It has some small fibers that travels towards the lower lip, but the majority also goes to the modiolus, yes.
Okay, so it does it both. But it has a wide base over here, and then it sort of narrows down as it gets closer towards the lip. So where would be the safer area to inject?
Do you want me to show you that?
Absolutely. If you're ready.
I'm ready.
We are ready. You can show DAO, and before I inject it, we've already injected mentalis, but you can show us mentalis, DAO, and we'll talk about rhizorius also in a minute.
So just to show you this relationship here, so when we reflect the skin, which I did here, we reflect the skin, and then this is the layer of subcutaneous fat. I did not do anything to the layer of subcutaneous fat. I just left it as it was, and you can see on this underside, it's just a little bit of, almost nothing attached to this one. So this is the layer of subcutaneous fat that you feel, and you can see in this area here, you don't have a lot. This is your marionette zone, or also called the pre-Joel sulcus. All of this is this area here, and you don't have a lot of subcutaneous fat. In this area here, well, yes, you do have substantial amount of subcutaneous fat, and here also, but this fat here is different of structure, and is different in terms of the fact that it is connected to muscles. And the reason why this fat here looks a little bit different and is connected with muscles, because the muscles need to move the skin. If there's a layer of fat, like here, this gliding zone, the underlying muscle cannot move the overlying skin because there's no direct attachment. As opposed to this area here, where you do have a very precise connection between muscles and skin, and this is why you have very precise facial expressions. So if I move it to the other side, and the camera can just stay as is, that's totally fine, sorry. So I dissected here the skin inferiorly, because I said today in the morning we had some time. And the layer of subcutaneous fat here, this one goes up, and this layer of subcutaneous fat that we have here goes down. And this exposes the entire area where I dissected the muscle. So just look at a little bit. I left this, this area of skin here attached because this is your midline, so that we don't lose the reference where we are. So this is all the midline here. You can see skin and subcutaneous fat. And here, if we focus now specifically on this area here, you can see very precisely the DAO. I'm putting this over there. See how this muscle is really like a triangular shape? This is your DAO, and you can see that the DAO is superficial to platysma, because platysma is here. This is all platysma. Can we zoom out? Yeah, perfect. This is all platysma here, all platysma. But here in this area, you can see how the DAO lies superficial to the platysma. You can clearly see this. This is why you can understand toxin administrations for the DAO have to be superficial, because it's the most superficial muscle in the lower face that we have. As opposed to this other fellow, which is here, which travels to the lower lip, as you can see here, this is your DLI. And just try to see. It's these fibers that you can appreciate here. They travel deep to DAO and then just continue with some parts of the platysma. Is it visible that the fibers just continue? Because on my screen, It looks a little bit small. So again, it's just really important to understand DAO, superficial to DLI. And now my question, do you see these fibers that travel this way? Any idea what the name of this is? Yes, exactly. That's Eurosorius. This tiny little thing here that goes almost posteriorly here, this is Eurosorius. It's also very superficial. It's a very superficial muscle. And we just need to understand the respective relationships of all of this muscle. And if you look at them, they don't look as clear, as delineated as they do in the anatomy books. Like, this is this muscle and this is the other muscle. The reason is because they're all interacting with each other. They're all connected one with the other, and they're all interwoven. So they're not separate muscles. And if you think about why, well, because Mother Nature designed them to do facial expressions. But every facial expression that we have is not a single muscle contraction. Facial expressions are multi-muscle actions. And this is why it makes sense that the muscles are connected with each other, because if your brain tells to the face, you do this movement, it's not only one muscle, they're all acting together as a unit. So I think this should make sense. And now if we look into the midline, because in the midline, I dissected for you the mentalis. I'm reflecting orbicularis oris, and you can see here that on this area, it's a little bit darker. Can you see this area? This is the area where your mentalis muscle originates from the bone. Normally, and it's subject to variation, it's two parts, one here and one here. Sometimes it's one part, it just depends. This is anatomical variation. But from this area, it travels to more superficial areas. So if you look at this relationship here, I think you can clearly see how the mentalis muscle is located. So let me rotate this a little bit more. Focus here, please. Can you see how the muscle from the bone travels and becomes more superficial? So when this muscle contracts, he does two things. He brings the chin up from this location into this location, and he can bring the skin downwards, like putting the skin in the areas where we have muscle fiber connections to the skin surface. This area will be pulled inferiorly. And when you pull it inferiorly, it can cause surface irregularities, the so-called chinulite. So these are the actions of the mentalis muscle that you can see here. And if you ask yourself, but wait, what are these fibers here? Can you see them here? These fibers superficially?
Hola.
Connects with the superficial fibers of mentalis muscle. They're all interconnected because facial expressions are multi-muscle actions. And this is how your orbicularis oris looks like when I'm putting just back. All of them connected together with the overlying skin. But when you reflect them, you can kind of really separate them with each other and can identify where is what. So with this, I think we have a little bit of a muscular understanding of the lower face anatomy, but we will cover later on much more when it comes to fillers or when it comes to talking about nerves, where the danger zones are.
We're back to me. While he was talking, I injected her mid-face because we didn't do that yesterday, just with the techniques that I showed you. Several pillars coming across over here. And then I used a cannula to go over and coat the top over there. So we're going to be able to see that result in a minute or so. I'm just going to finish off with her toxin. I'm just checking to see how we're doing. We've created a cheek light reflex high up. Can I have, give me, let's see now. I'll take, yeah, I'm going to do this so you can give me 2 units. I'll do the other side too so you can give me 4. If you already have it prepared, of course you do. So my way to do the DAO is to look at the line coming down from the marionette zone, which we call the marionette line or fold, and to stay just lateral to it and close to the mandibular border. Is that muscle superficial or deep? Superficial. So I'm going to go in just under the skin, and I'm going to put in 2 units over here, and I'm going to do the same thing on the other side over here. And that's treatment of the DAO, okay? So we've done mentalis and DAO. Can you clench your teeth? So she has baby masseters. I'm not going to inject them. Maybe the next patient will. Masseter injections were taught to me by my friend Waffles Wu from, great name, huh? Waffles Wu from Singapore and Stephen Liu from Australia. They do a lot of facial slimming over there to use that for the masseter. And I'm going to just show you basically the landmarks of what you want to do when you're injecting a masseter, okay? For masseteric hypertrophy, you obviously palpate the patient and feel how much of their bulge is there as a result of the masseter. Sometimes it's difficult to distinguish between a masseter that's large and a parotid that's large. How do you tell the difference? Well, you do it by putting your fingers on and asking them to contract. Everything will push out, of course. But the interesting thing is that the masseter doesn't cover the gonial angle over here where the two bones meet, the vertical and the horizontal ramus of the mandible. The masseter will go just about to the gonial angle. But when you have a parotid that's been hypertrophied, you're going to blunt out that area. She has a little bit of parotid here. You can see it. It's almost like a C. It comes up behind the ear a little bit. Do you have that on dissection?
Yeah. Do you want me to show you this?
Please.
Of course. So let's focus on this area. Again, as I'm reflecting the skin, and those of you who know my dissections, you know I never dissect from medial to lateral. I always dissect from lateral to medial. But because we have two dissection approaches where we go later today also into the neck anatomy, and I'm curious how we're gonna elaborate on the quiz because I dissected some very special structures for you. I had to do the medial to lateral skin, but I will do now lateral to medial platysma and subcutaneous fat. You can see here, this is the platysma undersurface. You can see the muscle fibers, how they travel towards the modulus, and I'm reflecting this area from lateral to medial. And here in this area, you can of course see this structure here. What is this structure? Yes, that is the facial artery here. Slightly posterior to this, we have this big fellow, which is normally blue. What is this one here? This is the facial vein, correct. This is the facial vein. And then on top of that, we have these tiny little white fibers. Do you see them? These ones and these ones here and the other ones that travel far anteriorly. Any idea what that is? Which one? Correct. These are all facial nerve branches. Marginomandibular, here you have the buccal ones. Here, up here, you have the zygomatic branches. As you can see, all of them come and arise from the parotid, which we have here posteriorly. And the parotid is covered together with the masseter muscle, which we have here. This is your masseter muscle. Do you remember the shiny tendon yesterday that I showed you during my dissection? This shiny tendon is high up here, but it's still covered. But here in the lower aspect, here you have the muscular component. And all of this is masseter muscle. All of this is masseter muscle. And posterior to this one, you have this structure here. This is your parotid, right? And now I would like to show you how large the parotid sometimes can be, because now I'm rotating this around. Perfect, thank you. Here's the mandibular angle. It's this area here. But look at this. This is all your parotid. And you can imagine when this parotid gland is enlarged, of course it can mask the angle. How can you have a proper angle when you have all of this glandular tissue lying on top of this? Of course it does not work properly, right? So this is kind of sometimes what Arthur just said is the mandibular angle and the shape, especially of this area here, which normally should just be bone. Because here is my ramus, and here's my body. So this is kind of the nice contour that I should have. But all of this can be masked by the parotid gland that can be here. And again, the parotid gland really loops around the angle, also from the inside. And all of this here, well, if you're not afraid of the structures, all of this one here can be covered by parotid. All of this whole entire space here can be all covered by parotid.
That's great. Thank you. Beautiful demonstration. Beautiful, beautiful demonstration. So if I'm injecting the masseter, here's a couple of things to consider. If the patient's over 40 or 45 years of age, you're going to take away volume from the lateral aspect of the face, and I just showed you which way the skin's going to go. It's going to go this way. So if you decrease the bulk of the masseter over there, you might end up causing a small jowl as a result. In a younger patient, they'll retract and you won't see that. Okay, so keep that in mind, and I'll explain to you how you can treat that in a minute. What I've drawn over here is I always draw my lines when I'm treating masseter, because the one thing you don't want to do is hit the rhizorius. If you hit the rhizorius, it's a devastating injury for 6 months. So what you do is you draw a line from the corner of the mouth, I love that corner of the mouth, to the earlobe, okay? And then you ask the patient to contract their masseter by clenching down their teeth, and you feel for the anterior border of the masseter, and you draw a line where the anterior border of the masseter is. And then I give myself a 1 centimeter or so, or ½ inch, window of safety, so I do not want to inject in this area over here, because the rhizorius is taking origin from here and going towards the modiolus. That leaves me this space over here to be safe, or the safer zone to inject the masseter. When you have the patient contract and clench, that's the area that you feel the most bulk of the muscle, and that's why you're going to target it. And you can target it in 3 different injection points, whichever way you want. It could be a pyramid, it could be vertical, it could be whatever you like, as long as you stay in this zone. And the question then becomes, well, what's the depth of injection? I always want you to think, whenever you stick a needle into a face, is what depth am I targeting? What is it that I'm targeting at that depth? And what are the vital structures that I may have to avoid? Those are the things to think about when you're sticking a needle in a face. Well, the masseter is an interesting muscle, because it's really probably more than one muscle. It's probably an association of 2 or maybe even 3 muscles, because if you look at the way the fibers run, and I don't know if Sebastian can show you that later, because he's doing this other dissection, but it's a very thick muscle. It's actually the strongest muscle in the body. You can generate more pressure per inch by biting than you can with any other muscle that you have, which is kind of, per surface area. That's amazing. So the problem here is that I want you to think of terms of the muscle being in layers. And in actuality, when you do an ultrasound of the masseter muscle, you can see that there's a fibrous type of septi, or separation, that's inside the muscle. If you think in terms of, very simplistically, superficial and deep muscle that's working here, what happens is that a lot of people who use BD2 needles for their toxin, like I just showed you over here, will use their BD2 needles to inject masseter. But that's just injecting the superficial aspect of the masseter, and you leave the deep one untouched by toxin. What happens is that a couple of days later, when the patient bites down, they get a walnut that projects through. Think simplistically in terms of the fact that the superficial masseter is there to tighten, to keep the deep muscle from herniating. And if you loosen the trampoline over the top, you're going to see the bulge of the muscle. So our injections have to be deep. So when I inject masseter, Catherine will transfer my toxin from my little BD2s into a 1 cc syringe with a ½ inch needle of 30 gauge. Got it? And typically we're talking in most individuals, a reasonable dose to start with is about 30 units of Botox or Zeo, or 75 units of Dysport. Okay? So your injections, she doesn't need it, are going to be deep. You put the needle in all the way up to the hub. So you're going in deep and you're putting in 10 units in each of these little injections. For the Asian population, because they have Quite large masseters, you may have to use 40 units. And the amazing thing about it is that the masseter starts to slim very quickly. So you can bring a patient back, and we do this for patients who have a history of bruxism, where they're clenching their teeth at night. You can tell the difference between a clencher and a grinder. A clencher will have both muscles hypertrophied because they clench right down. Somebody who grinds has a tendency to grind more on one side than the other, and they'll get a unilateral hypertrophy of that masseter, okay? And it's a great thing to treat. Patients are very, very, very appreciative once you do this and you take away the stress over there. It's the #1 area of injection in Asia. When I was in Korea, I've never seen this in my life. They have an aesthetic center in the center of Korea. It's called the Aesthetic Center. It's 4 blocks, and in that 4 blocks, they have 400 plastic surgery clinics. South Korea is the #1 area for plastic surgery in the world. Most penetration per population, something around 60-something%. And the #1 procedure that's being done is facial slimming. They like the V line. It used to be done surgically. Now with injections into the masseter, it's a lineup. I went to a clinic that does 4,000 injections a week. 4,000 patients a week. 80 doctors, 1 clinic. It's amazing. When you go into the reception area, I can show you a picture of this. You go into the reception area, you think you're going to get your passport. There's about 12 receptionists with 12 different chairs, and they say serving 102, serving 103. I walked into this, the place was packed. There wasn't a person over 35. I was the oldest by 30 years. It's an amazing thing to see, and they inject masseters like crazy. And what my friend Waffles has shown me, and he's the one who's been doing this for 16, 17 years now, is that with repeated injections of the masseter, you lose the trophic effect on the bone, and in actuality, the bone starts to reshape and slim. And you can get permanent slimming of the lower face with repeated injections. So this is the way that you do masseters, okay? You bring them back. Waffles does it until he can't feel a palpable movement of the masseter, and they still can chew because they use their pterygoids, and they'll get a little bit of temporal hypertrophy because they use their temporalis muscle a little bit more. So be prepared for that if you're going to go ahead and try to obliterate masseter movement. They try to obliterate masseter movement because they have very strong bone structure over there with facial width, so they have to take the masseter down all the way. But I'm telling you that when you do masseter, for some reason, the muscle starts to thin out or slim right away. Whether it's because the muscle fibers become elongated or whether there's not an actual atrophic effect, but you'll start to see your lower face slim quite rapidly. What I'm going to do on her now, because we're going to start to stick needles in her, I'm going to have to do something and find body parts in my fridge tonight because I have to release that inner demon, right? What we're going to do is we're going to do a lower facial tightening. Now, we did the injection up over here, which helps with the vertical aspect of the face, but what I'm going to do is I'm going to try to tighten up the lower part of the face over here. And this is what I do in patients, especially when I go ahead and treat the masseter, because I'm going to lose volume over here. You don't want to put volume back where you just try to obviously try to slim them, right? But what we're going to do over here is we're going to do something that people have been calling the swift lift, which is like Sebastian, it's not the C line for Katafanu, but what I do is I call it the doorstop technique. If you imagine that things are swooping in like this, and that jowl is coming from this type of situation right here, which is causing the curvature that we have over here, right? Then I'm going to try to reset the skin this way. There are a bunch of little ligaments that are over here, over the parotid-masseteric fascia, a ton of them, which we call false ligaments, not true ligaments. And why are they false? Because they don't originate from bone. They originate from the fascia over there, pretty much the SMAS, and they come up to the skin. Again, simplistically thinking, I think in terms of the true ligaments, which Sebastian had shown you yesterday, I think of the true ligaments as being the things that prevent our facial envelope from sliding off the skull. That's what they're there for, right? And those true ligaments, as he showed you yesterday, are like tree trunks. They're thick. And if you take a look at the studies say they don't really stretch much, but they do flop because they lose their support from underneath from the loss of volume. So they'll flop. These false ligaments, on the other hand, are more sort of rectangular shaped, and they can stretch, they can lengthen, and when they flop, because things are going in this direction, they'll kind of flop maybe forward like this rather than down vertically. This is the way that I think. Whether it's true or not, I don't know. And I thought, well, wouldn't it be cool if there was a way that we could pull the skin back, so we verticalize, just like Sebastian showed you with a major ligament, we verticalize those ligaments, and then put a little product over here to act like a doorstop so that the door doesn't close again. So it's just opening the door, putting a doorstop, opening the door, putting a doorstop. I'll take the product. I'm going to use RHA3 here. I choose a product depending on the type of skin. She has thicker skin. I can get away with a higher G' product, but I want something that is definitely cohesive. Would I use Resty or Lift here? No, but I would use Refine or Define. Would use Ultra or Ultra Plus, very cohesive, okay? These are the type of products that I would use over here, and I could use RHA, which is also very cohesive, and I'll choose 3. But if it's a patient who's an elderly patient that has very thin skin, I'm gonna use RHA2, because I don't wanna leave little bumps. So what do? This is called the drop technique. And what I do is I look along the jawline about 1 centimeter above the jawline. This is all in your books, so don't have to worry about scrambling to get it down. It's all very nicely written out in your books. What I do is I pull the skin back. Do you see this? And then I lift the skin. You're going to feel, I flatten my needle out, and I let the skin fall onto the needle. Did you feel anything over there at all?
No.
Oh, no, I don't think so. And the needle now is up to its full hub. Do you see that? And now you can wiggle it. The reason that you can wiggle it is because I'm not in the fascia, she wouldn't be happy about that because that would be painful. And I'm not in the dermis, so it's not stuck. I pull the skin back, I pull my needle back with it, and I put in a 0.05 bolus. And then I withdraw. You got that? So you drop the skin, let it go up to the hub, put in your 0.5, pull everything back, put your 0.5 in, okay? And then pull out. You're not putting a linear trace, you're putting in a little doorstop. Little flick, back. Now look, I have the skin pulled super tight here. I can't pull it any tighter, but look what happens when I do this. You still see movement down at the jawline over there because I'm pulling on those little parachute strings, okay? I'm pulling on those little parachute strings that are attached to the SMAS. You get a little bleeding or whatever the story is, you just cover it and you continue. Little flick, pull back, inject. Little flick, pull back, inject. Now, how far forward should you go there? Well, is there a ligament at the anterior border of the masseter? That is called the masseteric ligament.
Yes, there is one.
And then you'll tell us why it's really not a masseteric ligament, right?
That is true. So when we look at this one and we go into this area, I'm reflecting this again anteriorly, and you might realize it's a little bit, it doesn't look very clean, right? It's just a little bit like, what's going on here? So what happened is that all of these structures here, you see these tiny little fibers? This is all facial nerve. So when you perform surgery, you never ever want to see those guys. But what happens is that these fibers travel superficially to the vein. I think you can see this here best in this instance. Here you have a vein, and you see that these fibers travel superficially to the vein. And what happens is that the vein has a canal. It's called the facial vein canal. I published that in 2017. Because the parotidomasseteric fascia, the fascia that comes from here posteriorly, loops down and attaches to the buccinator muscle. And this is the so-called the facial vein canal. But the facial vein canal has a roof. And within the roof of the facial vein canal, these nerve fibers change their plane. In terms of from deeper structures, they become more superficial because they need to reach the muscles of facial expression. Very similar to what the zygomatic branch nerve does here. You see this? Here it's very deep here, and then at some point it becomes superficial because he needs to reach the zygomaticus muscle. And while it does that, it's still enveloped in this fascia here. I think I just left this a little bit attached in this area. And this fascial adhesion that you can see here is nothing else than connective tissue that guides the nerve to reach more superficial planes. I repeat, connective tissue that guides the facial nerve branches to travel from deeper to more superficial layers. And these connective tissue guidance structures, because they are located in close proximity to the masseter muscle, but have nothing to do with the masseter muscle, these are called masseteric ligaments. Even they have no attachment to the masseter muscle, no nothing. And there's nothing else than this is the roof of the facial vein canal. But this is kind of one thing that sometimes a little bit confusing in the literature. And you just have to see it. Facial vein, all of these other structures traveling superficial to the vein, and that connective tissue here that you can see here and in this area where left it attached, these are your masseteric ligaments.
Really a beautiful demonstration. So there's no reason for me to continue that row of injections beyond the quote-unquote masseteric ligament, okay? It would just be adding weight to this part of the face over here, right? So I do a row, usually of about 4 or 5 injections of 0.05, spaced about 1 centimeter apart, flicking the skin down, letting it go right to the hub of the 1/2 inch needle, making sure that you can do a little wiggle to make sure you're not too deep. We're targeting those little fibers that are coming up, that are attached from the smasa and going up to the dermis, okay? And then if it's a patient who's very heavily jowled, I'll do a second row about 1 centimeter or 2 above that, okay? So this is pulling back with the skin and then pull the needle back as well. You can use a 30 gauge or a 27 gauge needle. Can I have a little bit of arnica gel, please? How do we do here? Didn't bruise her? Good. And because you're putting in small amounts like that, you're not adding volume back to where you might have, basically, where you might have reduced a masseter. Okay? And the idea is just to give her a little bit of tightening, like you see over there. Okay? So we can see over here that she has still on this side the jowling over here, but look at the straight line that we have on this side. This is, and you can see the jawline definition that we get over here as well. This is my #1 practice builder right now. This is what patients are calling my office and saying, can I get that lift?
Se demoró, ahora parece una película de terror. Se demoró el tren porque pisó un animal en el camino. No, parece un cuento chino. No, no, no nos vamos más. Estamos de las 12 del mediodía esperando ahí, ¿no? No, no hay nada encima de la estacioneta.
No hay ni baño.
Pisó un animal. Sí, ahora tenemos que esperar 2, 3 horas más. Va, no sé si 2, 3 horas, pero 1 hora seguro. Sí, pues
Lo peor es que va ascendiendo, porque arrancó con 25 minutos, después con 40, después con 45, después 50 y ahora 1 hora.
así que ya
No vamos más.
estamos caminando por acá por la estación porque tengo los pies hinchados, no demás. Pero hay que ver cuando están velando al animal.
No sé, sí. Están haciendo una autopsia.
Sí, no sé. No sé, se demoró porque pisó un animal. No sé qué, bueno, pisaron un caballo. Parece no sé por qué tanta demora por pisar un animal.
O si pisó el animal de ese tren, que manden otro tren.
Claro, que manden otro tren de última, pero no. Están esperando. Pero bueno, estamos, estamos literalmente de las días esperando a irnos. Salimos del hotel a las 10 de la mañana. Todavía no terminó más este día. Pero bueno, pero los viajes no son viajes si no tienen alguna cagada. Pues, bueno, ahora les aviso cuando nos vamos, porque hay que esperar ahora. Dale, más. Mandale eso, papá. Empezamos.